Greetings from Lusaka, Zambia. I'm Constance Njovu, Regional Coordinator for the East of Flowers Cross-Border Malaria Initiative. I would like to welcome you all here to the JC Flowers Foundation webinar, hosted in partnership with Harvard's Defeating Malaria from the Genes to the Globe initiative. Over the next 2 hours, we will be hearing many different perspectives on malaria from members of civil society, of the private sector, and of government. The webinar will be organized into 4 panels, each of which will have its own question and answer time. May we all learn something new today and put it into action as we leave today's webinar. I would now like to introduce Alexandra Gordon, Program Director for the East of Flowers Cross-Border Malaria Initiative, who will be explaining translation and running through some technical aspects. Alex, over to you.
Thank you, Constance, and welcome everyone. I will now be taking you through all of the webinar controls available to you. If you have any technology questions during this webinar, we ask that you email mmugore@jcflowersfoundation.org. That's Mati, and she'll drop her email into the chat for reference. So at the bottom of your Zoom window, you should see each of the icons pictured in the slide. Click the chat icon if you would like to send messages to panelists or to the meeting host. Click the Q&A icon to type questions for panelists. And questions will be answered at the end of each session as time allows. This webinar is taking place in English with options for interpretation in Portuguese or French. If you will be listening to the webinar in English, you do not need to use the language interpretation feature. To listen in Portuguese or French, you just want to click the globe on your toolbar and select the Portuguese or French language channel. Now, depending on your screen, you may not immediately see all of these settings in your toolbar. So if that is the case, you'll click the 3 dots to the right of the toolbar labeled More. And finally, I'd like to note that because internet quality fluctuates dramatically in many of the places where all of our participants are coming from, some of the statements you'll see today are pre-recorded, but in most cases, we have those speakers joining us as their internet allows to answer questions. So next, I have the honor of introducing the Right Reverend Cleopas Lunga of the Anglican Diocese of Matabeleland, who will be providing some opening remarks.
Thank you very much, Alex, for welcoming me to this. And warm greetings to you, brothers and sisters in Christ. It was a sad moment and sad time in the history of the Flowers Foundation when we lost Bishop David Njovu. David Njovu was a bishop of Lusaka, but a faithful servant of God and a friend of mine. He was an advocate of those most vulnerable, and he demonstrated that right up to the end of his life. Bishop David knew he was dying of cancer, but was never afraid. He exhibited that by undertaking a journey to attend an activity focused on the elimination of malaria, Zambian commemorations of ending malaria. He was my mentor in this initiative, as the Diocese of Zambia had already started working in partnership with Eastern Flowers Foundation. And later on, my own diocese joined, and alongside the Diocese of Zambia and other partners, we worked together to fight for the elimination of malaria. Bishop David had a way of putting the fight against malaria in a theological context and enabled the foot soldiers to aim properly, but also to enable the leadership in his own country to focus. And His Excellency, the President of Zambia, attended his funeral in recognition of the contribution that Bishop David made in the fight against malaria. He enabled the donors and the directors of this initiative to actually comprehend the immense dilemma of the beneficiaries, people who either could not go to work or to school because they are affected by malaria. And the directors and donors are able to know how genuine the beneficiaries are and appreciate their work and contribution to this project. Efforts to create interfaith partnerships was also Bishop David's passion, that all people of all faiths should come together and fight against malaria. As a faith leader, he believed in God's power of healing, and that he would not, although he would not recover from cancer himself, but did not deny others the opportunity to live, and those who might otherwise be affected by malaria. So he fought even when he himself was ill. My friend and brother lived a life of truth, but also a life of integrity. His tireless work earned him the nickname Bishop Malaria. We will continue to be inspired by his passion and work. And I know that the communities in which he visited, the communities he visited, appreciated his work. His neighbors, and one of the other passion was that he saw each and every person around him as a neighbor, and you and I were his neighbors, and the people and the communities where he served. David loved his wife Noreen and children and grandchildren, and he wanted to see them comfortable and also free from malaria. We entrusted the soul of Bishop David to the Almighty God, and in the trust that he would be cared for until we meet him again. And may I, with these few words, now hand over to Chris Flowers, the co-founder of the Eastdale Flowers. And we thank Chris and Anne who have contributed immensely to make all this project a success. Thank you.
Thank you, Bishop Cleophas, and good morning, good afternoon, and good evening to all of you. We welcome you to today's meeting, Rethinking Malaria Leadership, how a diverse group of malaria advocates is addressing a society-wide problem. This event is co-hosted by the Flowers Foundation and by Harvard's Defeating Malaria from the Genes to the Globe initiative. Anne and I want to give a warm welcome to our partners who have joined this meeting. There are too many to name, but we are grateful to our Ministry of Health, NGO, and academic partners. We are particularly happy to have numerous faith leaders and malaria implementers at this meeting, including those who are part of the Eastdale Flowers Cross-Border Malaria Initiative, the Anglican Diocese of Angola, Namibia, Lusaka, Zambia, and Matabeleland, Zimbabwe, and also the Methodist Church in Zimbabwe's Harare East District. For those of you who don't know us yet, the Eastdale Flowers Cross-Border Malaria Initiative is committed to malaria elimination through community mobilization along the shared borders of Angola, Namibia, Zambia, and Zimbabwe. We believe that malaria can be eliminated only if those most affected have the knowledge, the skills, and the resources to prevent and treat the disease and to advocate for its elimination. With the support from the Gates Foundation, we also partner with faith leaders who are equipped to advocate for malaria elimination through the FLAME initiative. The vast majority of people in these 4 countries describe themselves as people of faith, and therefore local churches are well suited to engage in the fight against malaria when they work in collaboration with ministries of health. Ever since the Flowers Foundation began its community work in Southern Africa nearly 20 years ago, we've convened annually as a team. With the limitations of COVID and the opportunities of increased global internet access, we turn to an online conversation today. Although we miss our in-person gatherings, the most recent of which was in March 2020 in Victoria Falls, we are delighted to gather together as a much larger group, which today includes people from 92 countries around the world. We know many of you, but others of you are new to us, and we hope to get to know you better one-on-one in the future. And we also hope to see you in person next year. The purpose of our gathering today is twofold. First, staff and volunteers at the Isdell Flowers Cross-Border Malaria Initiative, an opportunity for them to reflect on the current challenges, lessons learned, and ways forward as we work towards malaria control and elimination in Southern Africa. Secondly, for us all, as a global malaria community, to listen to diverse perspectives on malaria control and learn from people who are not normally part of our everyday conversations. This is a critical time for our collective malaria elimination work. We recognize that globally, the dramatic process against malaria made during the last 2 decades has plateaued in some areas. COVID-19 has challenged us further, though we are grateful that COVID has not provoked all the malaria setbacks that we feared it might. In our work, we have been delighted to see that community networks have been able to maintain essential malaria diagnostic, treatment, and education work despite COVID-19, partially due to the trust that community members have in their fellow community health workers, and due to their own intrinsic motivation as the health of their own families is at stake. Hearing from those who are directly affected by malaria is critical, and we have brought some of those voices into this meeting. Thank you all for being here, and I hope we will leave this webinar today with a renewed commitment to malaria elimination. Thank you.
Thank you so much, Chris, and good day to all. My name is Leslie Ann van Wyk. I am the Regional Advocacy Advisor for FLAME, and I have the honor of being a co-moderator for this webinar. So let's start our first session. Beginning in late 2020 and over the course of 1 year, Harvard University convened more than 200 stakeholders to share their views on malaria challenges and opportunities in the context of COVID-19. Co-chairs from this group of experts shared key recommendations for novel approaches to malaria control and elimination, and we'll be discussing some of them today. Our first session is titled Beyond Health. Our panelists will speak from their own experiences and share why malaria is a society-wide development challenge, whose solution must also be multi-sectoral and not just medical. Our panelists are Dr. Corinne Karema, who is the interim CEO of the RBM Partnership to End Malaria. We also have with us Bishop Andres Juarez of the Anglican Diocese of Angola, Dr. Cecilia Lodonu-Senu, Executive Director of Hope for Future Generations, and she's also a member of the Developing NGO Delegation to the Global Fund Board. And lastly, we have Dr. Julie Jacobson. She is the 2021 President of the American Society of Tropical Medicine and Hygiene, and also the co-founder of Bridges to Development. So I will now hand over to you, Dr. Corinne.
Thank you, Leslie, and thank you very much for inviting me to this webinar. Dear friends and colleagues, I've been asked to talk about the malaria as a societal-wide development challenge, whose solutions are not just medical, but also include multi-sectorial approaches. So I divided my talk in 3 points. So the first one is maybe it's to show you how we could take a broad view on how malaria affects society. So malaria may be a disease, but its impact reaches far beyond the health sector. So we know that malaria is one of the most public health problems worldwide. It is the leading cause of death and disease in many developing countries, where young children and pregnant women are the group the most affected. So when we look at the World Malaria Report that was released in December 2021, it showed the devastating toll of malaria, with an estimated 627,000 people losing their life to the disease in 2020. Those are our parents, children, mothers, and we all know that all of them could have contributed to our family lives, our country development, and etc. So according also to the World Malaria Report, malaria accounts to 1 in 5 deaths of children under 5 in Africa each year. This alone is a terrible injustice. However, malaria not only takes its toll in life loss, but also in medical costs, lost income, and reduced economic outcome. So malaria occurs mostly in poor, tropical, and subtropical areas of the world. So usually we all know that malaria and poverty are intimately connected, as both a root cause and the consequences of poverty. So malaria is most intractable for the poorest countries and communities in the world that face a vicious cycle of poverty and ill health. Malaria slows also economic growth and development and perpetuates this vicious cycle of poverty. So malaria imposes a substantial cost in both individual and government. So for instance, the cost of individuals and family can be money to purchase drugs for treating malaria at home, expenses for travel, to go to seek treatment and go far to look for a dispensary or a clinic. And then there are also loss of days of work, absence from school, expensive for all these preventive measures. And then for the government, we also know that there is expenses in terms of supply, in terms of staffing of health facilities, in terms of purchasing drugs and supply. So we also know that malaria changes in household behaviors that result, for instance, in some decisions related to reproduction, education. So because someone has used money to go for treatment, it cannot pay school fees for the children, and then all the economic matters. We also know that malaria can hurt businesses, reduce tourism, lower productivity, and so on. So for this reason, malaria cannot be viewed simply as a disease that requires medical solution, but its impacts on the whole society, and so our response should be the responsibility of the entire society affected by it. So ending malaria requires the whole community, including local, national, and global leaders, to come together to improve the life and the livelihoods of their communities. And these leaders at all levels should ensure priorities for their communities are integrated into malaria control and elimination. So that is why for the whole Back Malaria Partnership to End Malaria, we are having an overreaching strategy that focuses on convening and coordinating an inclusive multi-sectorial response to control, eliminate, and ultimately eradicate malaria. That is why in 2018, the RBM partnership to end malaria with the African Union Commission, we launched the Zero Malaria Start With Me. That is a Pan-African movement that mobilizes and empower all of society, from country leaders to businesses to communities, to take ownership over the fight against the disease. The campaign has already been adopted in more than 26 countries, supporting communities and at risk of malaria, but by advocating for stronger political will, leadership, oversight, and ownership, including increased funding and more targeted malaria elimination. So malaria continues to take its highest toll, but what is very important for us is it's really important to look at how the disease affects. So for instance, the disease affects only the poor. The disease affects women. For instance, women often take the burden, they take on the burden of caregiving due to malaria, not only in the household, but also as community health workers, with women accounting to an estimated 70% of the global health workforce. Yes, too often issues of gender equity have been overlooked. By taking a gender approach to the fight against malaria, country can also achieve a double dividend, accelerate progress towards ending malaria and advancing the gender equity. So we also know that the poorest households, who are least able to afford preventive measures and medical treatment, are therefore carry the highest burden of malaria and the resulting economic impact. So equitable access to resources at household, community, and health system level are crucial to enabling community members to prevent and treat malaria. So in conclusion, malaria is a societal-wide development challenge whose solution must all be multi-sectorial and not just medical. Only by bringing sectors and community together with a common goal can countries ensure that their essential health system to provide high quality care for malaria and accelerate progress towards ending the disease. So I will end by leaving you with a quote from Ellen Adams Keller, an American author I really love, who lectured and political activist who was blind but inspired many, including myself. She said, "Alone we can do little, together we can do so much." Thank you very much.
Thank you so much, Dr. Karima, for those very insightful perspectives. To catch up on time, we will try to move as swiftly as possible to our very next speaker, who is Bishop Andres Suarez. He is with us and will be able to answer any questions after the panel, but due to internet constraints, we have a pre-recording of his remarks. It's over to you, Bishop.
No nosso contexto que vivemos, temos a malária como a primeira causa da mortalidade, tanto das crianças como também dos adultos. E isto tem nos comovido em poder nos mobilizarmos e nos consciencializarmos para nós participarmos nesta luta. Sabemos perfeitamente que a malária existe e ela só vai acabar com o meu envolvimento. Eu sou bispo, não sou médico, mas eu entendo que combater malária ou eliminar malária não é apenas tarefa dos médicos ou dos doutores, nem dos enfermeiros, ou seja, da área do Ministério da Saúde, mas nós entendemos que este processo só pode ter bons resultados quando nós, enquanto líderes religiosos, a própria comunidade estar muito bem envolvida nesta causa. Não é necessário ser médico para combater a malária. É nosso ponto de vista, é nossa experiência. Estamos nesta área, na verdade, desde 2006 até agora. Nós continuamos a lutar contra a malária. Por isso, sempre apelamos que todos os líderes religiosos devem se engajar nesta luta. Porque é possível eliminar a malária. Há muitas nações que eram também endêmicas com essa mesma doença, mas conseguiram eliminar a malária. Por que nós não podemos fazê-lo? somos chamados para andarmos com mãos dadas a fim de podermos eliminar a malária no nosso seio, porque ela é, na verdade, um grande obstáculo para o crescimento e para o desenvolvimento dos nossos países, das nossas comunidades.
Thank you so much. Our next presenter is Dr. Cecilia Lodonu-Senu. Welcome, Dr. Cecilia. Over to you.
Thank you very much. Good afternoon. Good morning. My topic is essential roles girls and women must play in the effort of malaria. And I'm very happy to share a number of experiences and also talk to the issue. Gender plays a major role in determining risk and impact. Addressing gender equalities in malaria endemic countries has the potential to accelerate burden reduction and to help end malaria, and therefore malaria interventions cannot respond to vulnerable populations unless countries address community dynamics effectively. And furthermore, countries need to know what those dynamics are. And for example, people with malaria who seek treatment, often for multi-negotiations linked to a woman's ability to make decisions about her own health. This is often linked to finances. Women and girls are very powerful. They have the instinct, and I always share this experience. When many of us are children, our mothers, the moment you are sick of malaria, they don't need signs to know that you have malaria. They just use their hand to know that it is malaria. And immediately they know what to do. And that is what has really helped many of us to be alive today. And therefore, using women as change agents, girls as change agents will go a long way to translate and inform communities, families, and the whole community to know that malaria can be eliminated with the support and involvement of women and girls. About 76% of community health workers in developing countries are women. And these women are passionate about the work they do. They provide all the information to community members. They use existing platforms to talk about malaria. Their knowledge in malaria is very traditional, and they know that malaria is caused by Anopheles mosquito, which they have the local language and they mention it and they understand. These women and girls are the future people who make family, who contribute to population. And so we believe that they have a critical role to play when it comes to the effort of malaria. The mother's knowledge on malaria, signs and symptoms of malaria, cannot be underestimated. She doesn't need to go, if she go to hospital at dawn, if she knows what to do. Many of us know what our mothers have been doing. The first thing they will do is to use warm water when your temperature is rising. They know that we have to touch some parts and make sure that those parts are hot, so they have to reduce temperature. And we believe that this knowledge, this skill of our traditional women have contributed for a lot of things that we've been doing. I believe that national programs, countries, using women platforms, religious bodies, community groups, using youth and girls platform to create awareness of on malaria and signs and symptoms will go a long way to reduce malaria death. Our women in our churches, we already have low-hanging fruits. We have church groups, women groups, religious groups, mosque, and they all have their platforms that we can use to communicate malaria. And these women are leaders of health. Our mothers are caregivers. Our daughters are caregivers. And if the girl is trained early to know about malaria, it will really affect the health outcome of malaria positively. I remember when I was a young girl, my mother, she calls malaria fever. And the fever in my language is also high temperature, and she knows what to do. And so many of our mothers already have the knowledge. And I think this is the time to start using the community systems, the community groups, the youth groups, girls group, to give them the knowledge. And this will go a long way to support our malaria elimination efforts. I also believe that when you give this knowledge to these women, you don't need, they have the local language that they use, they describe. And I think countries should start looking at the skills, the capacity, the basic capacity women have to contribute to malaria. In Ghana, we use a lot of women to address many of our malaria interventions. The community health workers are very passionate. When you give them the skill, the knowledge, they go a long way. CS for Me is one network that, and I'm a part of CS for Me. We do a lot of work using women and girls. And that is why CS for Me is one malaria network that we must really support to ensure that it is doing the work that it is formed to do. It is bringing all of us together, the smallest women groups in communities, CS for Me interventions through the various countries are mobilizing them to support malaria. And I believe that using community structures, using women, using girls, community-based organizations is the way to go, apart from using the medical and other technological issues. But these are very low-hanging fruit we must not leave behind, but continue using. Finally, I just want to encourage us to know that civil society in malaria are there to work with communities. We speak the same language, we understand the local context, we are part of the churches, we are part of the mosque, we are part of existing groups that exist in our communities. We use the result, the recommendation from science to implement in the community level. I'm very grateful for the opportunity. Let's continue the engagement. Thank you very much.
Thank you so much, Dr. Cecilia. We will now hand over to our next and last presenter for this panel. It's over to you, Dr. Julie Jacobson.
Hello, very exciting to be here. And I come to you bringing a perspective from the NTD, the Neglected Tropical Disease community, to share and build off of some of the themes that you've heard from my other panelists. I know that we're running a little bit short on time, but I'm going to give you two examples of really thinking about and embracing innovation that comes from the field, from people who live at risk within the systems, within the communities that are affected by the diseases that we care about. And my first example of innovation comes from guinea worm. Guinea worm is a disease that is transmitted by drinking infected water. The parasite goes into the body, goes into the stomach, through the lining of the stomach, and then infects the body. 1 year after drinking the contaminated water, a worm then comes to the surface of the skin, creates a burning pain. Person puts their leg in water where the worm releases its eggs into the water, coming out through an ulcer usually in the lower limb, the leg, and that contaminates the water source again. And then people who drink that water become infected. There's no drug, there's no vaccine, there's no diagnostic for guinea worm. It's just the communities that identify the cases, find the contaminated water sources, can treat those to get rid of the parasite and filter the water. But how do people filter the water? And what they found is that they were giving water filters to people, and people would go to the water source, filter the water, bring it back home. But this didn't work for nomadic communities. And what they did is they would take a straw and take a little bit of the water filter paper and put it on and use that as a straw to drink water from and they would carry it around their necks with a little strap here. And I have this and I carry it with me to remind me of the incredible power of innovation that comes from the local level. And this then was transformed and brought into the entire community. My second example of local level innovations that transform programs, if we're awake and aware and and taking advantage of that potential comes from the digital revolution that's happening now, as demonstrated by this conference here right now. We've been working Bridges to Development, my organization, with a group called the Geneva Learning Foundation, which has been reaching into communities around the world, creating a way in which there's peer-to-peer based learning that's been helping to revolutionize across the immunization field. And with this, they've been able to reach over 40,000, create a network of over 40,000 people that work at the subnational and national level, over 120 countries, to share learnings and problem solve across programs, so that Malaysia is working with Namibia, who's working with Botswana, and all sharing ways in which to improve programs. And we can take the power of these new technologies and these new pieces to bring local innovation and share lessons learned across borders, and think about our programs in a whole new way of how we capitalize on this. So those are my thoughts to share with this group, and wonderful to be on this panel. Thank you.
Thank you very much. I'd now like to ask all those who are just on the panel to turn their video and mic on. We'll just have one question due to time. One of the themes that came out many times was the link between malaria and poverty, that malaria drives poverty, and poverty also makes malaria difficult to address. Do any of you from this last panel have examples of how addressing poverty has actually helped address malaria or other disease? There's a question talking about how so much investment has been made in technology, new medications. What about these questions of poverty? Any examples that can give us hope and give us wisdom for other areas?
Okay.
I'm afraid my example coming from the neglected tropical diseases is more on the side of the diseases that drive poverty, because they take people out of schools, out of being able to do their work, out of being able to be successful in schools. And by treating people, one of the interesting things is that we do a lot of deworming in schools themselves. And when that happens, you frequently get comments from the teachers about how, oh my gosh, the children now, they're so unruly because they now have energy and they're interactive. And that just shows you the potential that's there that needs to be tapped by treating, which allows people to be more successful and have that economic and social success.
So my contribution is similar. You know, with malaria, you cannot work. And I believe malaria is the only disease that affects every system in the body. And so the moment you have malaria, it affects your economic background, your income, your family, your nutrition, everything. And so when we are able to eliminate or address issues of malaria, I think it's one of the ways of encouraging and helping people to go back to work and make some income to survive. I also believe that the poor, you know, it affects the vulnerable population because they don't have the resources. And so if those populations, the key and vulnerable populations are resourced, they are mobilized to start some income generation, they will be able to make decisions that will help them improve their economic and power for negotiation. Thank you.
Dr. Karima, last word.
No. Basically, Dr. Cecilia as well as Dr. Julie have said it well. Poverty and malaria is really interconnected, and we have seen that when someone is sick, they have to increase expenses in terms of drugs, in terms of travel, as I say, to go to the clinics. And when someone is not sick, he can use preventive measure. This is some saving that can be used to invest and as well as develop the household income as well as the country development. Yeah.
Thank you very much. And thank you, panel. We will move on to our next panel. Thank you.
Thank you.
Thank you so much. Our next panel discussion is focused on health systems. We know that accessible and reliable health systems are essential, and our panelists will speak to the fact that strong health systems that include well-equipped health workers at every level are the foundation of malaria control and elimination efforts. Our panelists for this session include Olivia Ngu, co-founder and global coordinator for the Civil Society for Malaria Elimination. We also have Mukube Kayawe, district nurse from the Liuwa Plain, Zambia, and Monitor Shimango, a malaria program manager for the Methodist Church in Zimbabwe, Harare East District. We'd like to ask our panelists to please stick to time and keep it as short as possible, please. Olivia, it's over to you.
Yes, thank you very much. Thank you to the organizer for this great webinar. I'm with my sister Cecilia. I am here, and we're very happy to. Yes, thank you very much. I hope you can hear me. I'm Olivia, and I'm going to quickly talk about the access to malaria services, and also the key role that community health workers play in malaria. So as you know, malaria is a disease that today we are able to prevent and treat. We have the very effective tools to prevent the disease, and we can now today treat malaria simple malaria, at least in only 3 days. And we came from far away. We came from a time where we were spending days in the hospitals. We drilled to now having those pills who are highly effective and who can actually help us to get rid of malaria. So this is a fantastic innovation that we have. But at the same time, we are still seeing a high number of deaths and a high number of cases. So if you ask ourselves, why do we have this highest number of deaths still? It's probably because there are groups of people that we are still not reaching. There are certain communities that are still not accessing those amazing tools that we have. And we need to do something about it to close that gap and to make sure that we can advance equity and we can ensure that everyone has access to quality malaria services. I also insist on the word quality, because we also know in some of our communities, some group people in some neighborhoods, they are surrounded by fake malaria medicines that are there. They're also surrounded by some tools that are not effective. So we think as civil society organization that we definitely, like Dr. Corinne says and others, we need to move from a medical approach to include a very social approach to the disease and make sure we look at all the social determinants and that affecting those access to services. So those can be financial, cultural, physical barriers, but also barriers related to gender, like Cecilia was saying earlier. So looking at those different barriers and trying to identify which groups still do not have access to services, we will be able to develop malaria responses that actually address people's needs and not a one-size-fits-all approach, but really responses that are targeted to people's and communities' need and making sure that we include the diversity of the groups, the diversity of the different contexts, and we take that into consideration when we develop malaria strategies and malaria responses. And more importantly, this will be done effectively if we include representatives from this community at the table when we make those decisions about the different strategy. So making sure that we have community representatives who can meaningfully engage in the design of the responses will be critical, because then we'll be able to have specific tailored response, but also ensuring that they are not just recipients of services, but they are involved in the implementation, and they're involved in the monitoring and evaluation of those response at the community level. So all that to say that by doing that, we will reinforce our community system. I know we all know the importance of having strong health system, but for us, it's even also more important to develop a stronger community health system, because that will help us to not only prevent the disease at the community level, but to reach the communities that we are actually all failing to too rich and that are actually missing on those amazing tools that we have. And just to conclude, I would just conclude by saying that looking at community health workers and the amazing work that they are doing on the ground. It's really fascinating how we're seeing in countries how those community health workers are not even part of the health system officially, how they are not recognized, they don't have a legal status. They are the ones producing the most data when it comes to testing and treatment at the community level, but they are not very well represented in the health system and actually supported fairly for the critical work that they are doing. So it's really, really important that we look at that issue as a global community. If we want to end this malaria epidemic, we're going to have to make a lot of efforts to recognize community health workers, to ensure that they are fairly compensated. And I'm talking to our local leaders, our Ministry of Health, to ensure that they have more resources for health at the country level and that the specific line in our health budget for community health workers. And this will be really key to increase that access. Thank you.
Thank you so much, Olivia. Next, we will hear from Mukube Kayawe, a district nurse based in Liua Plain National Park in Zambia. Mr. Kayawe's remarks are pre-recorded and we hope that he will be available live to answer any questions during the Q&A session, internet connection permitting.
My full name is Mukube Kayawe. I am a nurse. I have been in service now for 7 years, and right at this station I have been. I'm now into my 5th year. The clinic was built in 2012, and then officially opened it to the community for services in 2015. Before that, the malaria incidences were very high because the transport, I think it's a major challenge from the community to the facility and from the facility to the first level. And especially during the floods, it becomes an issue. Traditional healers were there, they were cheating people because they were making their livelihood out of that. At that time, there were no skilled personnel per se to offer that technical know-how, the education aspect of it, and even offering the services like testing and the treatment. People had no access. But now with the building of this structure and bringing aboard the skilled personnel, we started seeing people now receiving quality education and the quality services. And we have seen higher acceptance levels from our community members because we've seen the area chiefs, the village leadership, the church leadership, they've come aboard and they've accepted it upon themselves that they will be engaged, because we see now people not living in houses or homes that are littered with longer grasses. We've seen higher acceptance of indoor residue spraying. All the households have been sprayed this year, early this year. And then not only that, insect-treated mosquito nets are being accessed readily available and they're accessed. And then from there, we've seen accessibility of testing services and treatment services. It's not only the government, but also the partners like Eastdale Flowers, that initiative of combating malaria right here in Liua. So there has been that will, and I think with these engagements, we can do it. And we thank them and we wish them they could continue.
Next, we will hear from both Monitor Shimango and his mother, Mrs. Nyarai Mirazi. Monitor and his mother were interviewed at their home in Mutsi district in Zimbabwe. We will now share their story, which highlights the importance of community health workers in preventing severe malaria and its consequences. Monitor will be available during the Q&A to answer any questions.
In Zimbabwe, the fight against malaria continues to be that of access to malaria education, prevention, testing, and treatment by people living in malaria-prevalent areas. While malaria treatment is available in most parts of the country through public health facilities, these are usually several kilometers away or a day's travel. The need to provide easier access to malaria treatment inspires this story about a community health worker, Monitor Chimango, who abandoned his studies to pursue his newfound dream of providing affordable access to malaria education, prevention, testing, and treatment. This follows a malaria ordeal that almost claimed the life of his mother, Nyarai Ngirazi.
Ndakanzwa musoro kurwadza nokupera simba nekunzwa chando. Saka pandakarara rimwe zuva rechitu ndakaona kana kusumuka chaiko ndasingatombogoni kana kudya chaiko ndasingadyi noti mukanwa mairo wawa. Rechitatu iri ndasingatombogoni kana nokuziva kuti ndiri kuitei. Baba ndo wakazofonera vana kuti amenyu kuno kuvarwara. Ndopaakazouya Monitor anzwa kuti amai kuvarwara. Ndobva wanditakura kwakuenda paMakaa clinic. Ndasvika temperature yanga yakakwira. Ndobva zvanzi hazviite kuti tivarape panapa ngavaende kuAll Source.
One day I received a phone call from my father and my young brother saying my mother is not feeling well. So I had to board a bus from Harare coming here to see my mother. I saw my mother in a blanket, shivering. We decided to hire a vehicle from this homestead to the nearest clinic, which is almost about 10 kilometers away from here, to seek help. She was tested malaria, and the result was malaria positive. We had to hire another vehicle to All Source, and we were charged 15 USD from Makaa to All Source.
Ndasvika kuAll Source ndofunga ndakarara. Rare mangwana yacho ndopandakazotonzwa manje kuti ingani ndamuchipatara ko ndakafamba sei. Kuti ndizoende kuchipatara urwere hwakura. Inhau yekuti kwanga kusina vanotibatsira kutesta kuona kuti malaria here kana kuti hakuna, nokuti hatina mahealth worker muno mumedu muno muchikwisi B. Ndosaka urwere hwakazokura chibva tazoenda kuchipatara. Apa tinenge tichitokumbira kuti dai kwanga tawanawo vanotibatsira, nokuti iko zvinozvi nyangwe tikarwara tikutofamba long distance yokuti tiende kuNyamatawa kana kwaNyamande kana kuti kwaChikwizu. Kwakarebesa. Zvino kana ari malaria tine vanhu vanotibatsira, ndofunga zvinokasika kuita sei, tinokasika kupora. Manje apa hatina vanotibatsira ndoti urwere huite sei unokura. Nokuti apa dzimwe nguva unobva ukamuka kuseni unogona kubatwa nemusoro wakanyanya kuti ufungidzire kuti ndibve pano ndiende kuMakaa. Zvinobva zvakurebera, plus unenge usina mari yekuti ukwire lift. Saka apa ndosaka urwere hwangu hwakanyanya kukura kuti ndizokwanise kuti ndiende kuhospital.
When my mother was discharged from the hospital, we had to hire another vehicle, and we were charged about 30 USD from All Source back home. From these two stories, that's where I chose this path to be a malaria, I can say, a health worker. Up to now, I am working as a health worker.
Motivated by his own mother's brush with death, Monitor now works full-time with the Methodist Church in Zimbabwe through the Isdale Flowers Malaria Initiative to improve access to malaria testing and treatment. He and his colleagues are now supporting a network of 108 community health workers who extend the reach of 10 rural health facilities across 6 wards in Muzi district. The community health workers provide malaria education, testing and treatment services to more than 15,000 households in 2021. The community health workers locally identified and promptly treated 4,090 people before their malaria became severe. By providing local care, community health workers can save lives.
Thank you. Monitor Olivia and Mukubi, if you could turn on your videos. A quick question for you, Monitor, and we'll have very quick responses. Monitor, if you were in charge, what would you like to see in every community in Zimbabwe in terms of malaria care?
Okay, thank you, Rebecca, for that question. I wish if every village had a community health worker who can test and treat malaria, so that the community, the people who won't travel such long distance to seek help at the nearest health facility. And also it encourage early treatment seeking behavior. Thank you.
Thank you, Monitor. And Olivia, you've talked about the importance of all levels being involved in implementation. How do you decide who should do what? Obviously, we don't think that those in a capital city who are medical doctors need to do the same as those with less education in a rural area. Who should be doing what?
Yes, so I think that's a very important question. I think we know that we have our National Malaria Control Program leading the fight and leading the development of the strategy, but our program should include the communities that are affected by those by those interventions. If we take the word "nothing for us without us," it means that the committee in charge of developing the strategy should just make sure that the recipients or the community's representatives are included in those decisions. So if we're going to organize net campaign in villages, yes, it's very critical that we consult with the communities, the traditional leaders, on how they think we can best have their population to use the net. I think we will be able to get even better strategy and better messages than the ones we thought at the national level. So it's just a matter of being very inclusive and making sure that the communities that we target are part of the decision-making spaces.
Excellent. Thank you very much, Olivia, Mukubi, and Monitor. Leslie, on over to you for session 3.
Thank you so much. Our next panel discussion is focused on leadership. Malaria control and elimination require multi-sector leadership at the local, national, and global levels. We will hear from a diverse group of leaders who are paving the way towards malaria elimination. And our panelists include Meera Venkatesan from President's Malaria Initiative and the USAID agency lead, a group of religious leaders from Flame Zambia, as well as Mr. Brian Jita, East Africa lead for Alma Youth Advisory Council and Chief Executive Officer and co-founder of Think IT Limited. We also have with us Monica Mvula, Program Coordinator for the Anglican Diocese of Lusaka Cross-Border Malaria Initiative. And lastly, Neville Isdale, former Chairman and CEO of the Coca-Cola Company and co-founder of the Isdale Flowers Cross-Border Malaria Initiative. You're very welcome, Meera, and it's over to you.
Thank you very much. Good morning, good afternoon, everyone. I want to start this session on leadership by saying that the President's Malaria Initiative work would not be possible without the essential leadership of Ministries of Health and national malaria programs in the countries where we work. Our annually developed country-led operational plans, which are the backbone for PMI programming, are designed in collaboration with national malaria programs to meet the needs they have identified in their national malaria strategies. PMI relies on strong collaborations with not only governments and other funders, but also local partners like faith and private organizations, many of which are represented here today. And we do this to ensure that interventions are tailored to the national, provincial, and district context, to engage communities to seek care and protect themselves from malaria. As Olivia and others noted, communities should be part of that decision-making, and for the effective management and execution of complex activities like prevention campaigns. We also rely on local leaders to tell us when we and other international donors are getting things wrong and work together with us to get back on track. We know that, as discussed in the first panel, without strong multi-sectoral leadership, there will never be enough resources to defeat malaria. This is one reason that PMI is a champion for End Malaria Councils, or EMCs, which are being established in many countries where we work. EMCs are helping to bring together parliamentarians, the private sector, faith organizations, and other leaders to advocate for resources to address national funding gaps. These partnerships are crucial to sustaining momentum to eliminate malaria. It's for these reasons that PMI's 2021 to 2026 strategy specifically highlights local investment as one of our 5 key focus areas. We believe that partnering with countries and communities to lead, implement, and fund programs is essential to win the fight against malaria. I'd like to share a few examples of how we're doing this. First, we aim to help our Ministry of Health counterparts from national to district level to strengthen their skills in leading and managing malaria programs. PMI has supported the Angola NMCP to, for the first time ever, lead studies to monitor anti-malarial drug resistance. This has come after previous years of investment by PMI in leadership and capacity strengthening of the NMCP, which has helped the Angola program to now take the lead in generating their own data for decision making. Second, we partner closely with local stakeholders to strengthen community ownership and implementation of effective malaria interventions. For example, in Ghana, PMI provides financial and technical assistance to community health management committees. They develop and implement malaria action plans. This is a sustainable and very locally driven approach to increase the uptake of malaria prevention and treatment. And third, we're building on successful partnerships for even more strategic investments in and support to local governments, civil society organizations, and local research institutions. So in Zimbabwe, PMI is investing in a local university to expand national and district capacity to conduct entomological monitoring. And these results really guide the selection of effective vector control interventions at the different levels. Ultimately, we believe that strong leadership from governments, the private sector, and communities, countries can not only defeat malaria, but also build stronger health systems overall, keeping more families healthy and safe. I'd like to end by thanking my fellow panelists. We at PMI are hugely appreciative of your strong partnership and your shared goals of local and country ownership to end malaria. Thank you.
Thank you so much. Next, we will hear from a group of faith leaders who are advocating for increased funding for malaria elimination and the policies that support it. It's over to you, Amu Mudenda, who will introduce the faith leaders.
Thank you so much for joining us for this exciting webinar. FLAME, which stands for Faith Leader Advocates for Malaria Elimination, is a network of faith leaders throughout Zambia who use their voices to advocate for malaria elimination, both at national and sub-national levels. The FLAME coalition represents at least 90% of Zambians who describe themselves as faith, whether they are Christian, Baha'i, or Muslim. Faith leaders recognize that they are trusted and have moral motivation and authority. They also acknowledge that malaria progress and has told domestically through advocates, and it's essential to have full availability and use of existing malaria control tools to eliminate malaria. They are now using their voices to advocate for malaria elimination. Along with advocates done, the End Malaria Council and the faith leader contacts with the National Malaria Elimination Center have put pressure on government. Malaria elimination could have this impact, and the faith leaders have achieved this together with the partners to have the doubling of the funding gap, at least for the malaria program, where budget allocation has increased to $5.6 million US, and also $11.3 million US for the malaria drugs. They have also advocated to solve local problems at local levels, to ensure that transportation of mosquito bed nets is done, and also to address stock out in terms of commodities. There are currently over 700 faith leaders in Zambia who are connected with this coalition. Join me now as we hear voices of faith leaders.
But we also need to talk to our policymakers because I think malaria is underfunded. We know of now COVID and how heavily COVID has been funded. If the same resources can be mobilized for malaria programs, I think we're able to see a lot of reduction. Our policymakers should begin to think about the issue of malaria as a critical problem that needs immediate attention and a lot of resources. So as they do the budgeting for the country and as they seek resources from outside, let them seek for more resources to be put in the malaria campaign, because malaria still remains even a more killer disease than the COVID-19.
When we talk of malaria, is one of the health matters that we've neglected lately because of developments of other health complications that are coming in. And I must say that even in the coming of maybe COVID-19, there's a tendency in which many of us have felt malaria is long gone, but believe you me, it's one of the deadly diseases, even in the prevailing moments.
We need to realize that as a church, we have the largest following, and we have a stronger voice in terms of influencing mindset change. So I felt it's a noble cause for us church leaders to partner with the Ministry of Health in trying to fight this very devastating disease.
But we realize that faith without science is handicapped, and science without faith is blind. And so the two need each other.
We've come to realize that as a church, we've not played a bigger role in terms of sensitizing our members how to spray for to kill mosquitoes, and to advise our members to sleep in mosquito nets.
It is clear to all that religious groups have the widest reach in the country, and government believes that this wide reach and network can be used to good effect. The church and other religious gatherings can be able to influence the people more effectively than anyone else, and this is the reason why we are gathered here this week.
So it is our very good move, and it's our opportunity to mix with other faith leaders so that we interact and share ideas on how to go about it. It is not that only Muslims can end malaria, but if we are together we can stand, and unity, always prosper.
Wonderful, thank you so much. Our next presenter is Mr. Brian Jita. It's over to you.
Thank you very much. I would first of all kick off by thanking every panelist for their submissions. And I'm going to dive in and talk about the role of youth in ending malaria. Successful malaria control requires the empowerment and engaging of a broader community, which includes the youth. In sub-Saharan Africa, where malaria is still endemic, accounts for 95% of all malaria cases and 96% of all deaths. In the same area, the youth make up 75% of the total population. This large population of the youth presents the advantage of a powerful and innovative workforce that is tied to unique qualities such as resilience, activism, and leadership for change and sustainability. This clearly indicates the need to invest more resources like capacity building, finances, infrastructure, and by infrastructure, I mean things like availability of internet, availability of tools, as well as evoking more inclusive strategies in order to empower and engage more youth in malaria control programs. We need to strive to convene youth under a unified umbrella with the same vision. This will help us create a multidisciplinary army of youth that can combat and suggest good strategies of ending or eliminating malaria. This also helps us to oversee and unite their efforts. For example, this is what ALMA, the African Leaders Malaria Alliance, is doing through structures like AYAC, which is the ALMA Youth Advisory Council, and the Malaria Youth Army deployed across Africa. These youth organizations are in positions to work on advocacy, communication, innovation, and direct action to eliminate malaria by 2030. More than 3,000 young people have been recruited, and over 1,000 of them were trained by ALMA on malaria advocacy, resource mobilization, health communication, monitoring and evaluation, and on leadership in 38 countries. These youth are raising awareness on elimination and the gaps that still exist for us to fight. For example, through the World Malaria Day, we organized a youth roundtable that was attended by over 280 participants to discuss the role of youth in the fight against malaria. We also organized other advocacy events such as Twitter space sessions and hashtag campaigns where we reached hundreds of thousands of people globally. That said, the youth need to accelerate and mobilize more through avenues like social media, with the examples shared above, peer-to-peer engagement, and community outreaches. We need to have more youth involved in these events and campaigns related to malaria elimination so that we can continue raising the awareness within this targeted population of the youth. You should be capacitated to work with communities and evoke more innovative strategies, such as community-level cleanups that help in the prevention efforts. Still at the community level, the youth need to create a layer of accountability to leaders. This requires knowledge of the mission of the national malaria control programs and how they cascade to the communities. Community-level agencies should continue to explore how they can support and review the impacts that have been achieved by the efforts of the youth. We should also be involved in policy advocacy around the challenges that have been highlighted by the different organizations and the malaria control programs. Finally, the youth should remain innovative. Innovation and science will continue to play a major role in the fight against malaria. We need to keep tinkering at all levels to get better ideas for elimination in the community. Thank you very much.
Thank you very much, Brian. We will now hear from Monica Mvula.
My name is Monica Mvula. I live in Mungu, in Western Province, in Chisonga. I work with Anglican Cross-Border Malaria Initiative. I'm the programs coordinator. Simulumbe is a neighborhood health committee within the catchment area of Simulumbe Health Facility. It is 45 kilometers away from Mungu districts. Mungu districts is 12 hours drive from Lusaka in Zambia. There are no roads. There is no communication. There is no transport. We use ox cart where it is dry, and we use boats to cross over to go to island or another village. So the houses are made of mud and pole, and they are thatched roofs. This is Senior Induna Muketoi. He has a subject, but he's the senior most. Senior Induna Muketoi has been working with a program in malaria, so he takes care of the community. He knows who is sick. He does a follow-up to ask that patient, have you been to the facility or have you seen the community health workers? Either of them. He asked, have you received your treatment? Have you taken your medicine? Have you finished your medicine? He convenes monthly meetings at village level. After discussing his traditional issues, he comes to health issues. He used to sing, Malaria kingiboma, malaria kibutuku, ape abulaya, ape kisikatani. What does that song talk about? What is malaria? Malaria is a disease that kills. Malaria doesn't care who is a baby, who is an elderly, who is who. As long as we are a human being, malaria will come after you. Queen lives with her mom and dad, who are peasant farmers. Queen has not been feeling well for some time. So when we visited, we found the daddy was not happy to see us. He didn't even allow us to do the test for malaria. So we said, what can we do? We need to help Queen. So we thought of engaging the village Induna to help us convince him so that we can test the little girl for malaria. So we engaged these traditional leaders who came on board and talked to the dad, convinced him. So we tested Queen, who tested positive to malaria. So Queen was given treatment. She was given Coartem. She was treated for 3 days. We did a follow-up and found Queen was perfect. We found her washing plates outside. We greeted her. How are you feeling? She says, I'm feeling fine. Did you finish your drug? She says, I finished yesterday. So what are you doing? I'm just cleaning the house. When do you go to school? I'm going in the afternoon. I'm happy that I'm feeling well. I'm happy to go back to school. What do you want to do when you finish school? She says, I want to be a nurse. Not only will I want to help my family, I want to help the community. At that particular time, there was Roger Sumuchu, who is our community health worker, who does door-to-door visit. He provides health education to families. He does tests for malaria when anyone in the family has a fever. He does refer the community to the facility where there is need for more management. He is able to test at community level. Why are they important? So we have the community health worker as first contact, who lives with them, who knows very well the community, who understands the language, who is able to show you where the problem is. So it's a passion in me that I realized when I was doing community work, and I realized I need to be there to solve that challenge. I need to be there. When malaria ends, I may be there, I may not be there. May I be there so that I should be part of the team that will eliminate malaria one day. I believe one day it will happen.
We will now hear from our next presenter, Neville Isdell, who unfortunately is flying right now and so has pre-recorded his remarks.
I'm very pleased to join you today to talk about something that I'm very passionate about, and that is the elimination of malaria from this earth. I have personal experience. I've had malaria twice in my own life. I lived in Zambia. And now over the last 10 years, I've been working with Chris Flowers and our initiative in the western part of Zambia to fulfill our role in elimination. And as a result of that, I've got some views I'd like to share with you. First of all, that we need to think about this as an end-to-end process. We start, you may be surprised to know, by educating people in terms of what causes malaria. There's still a belief in that area that it's caused by green mangoes, just like the Portuguese thought it was bad air, malaria. So you've got to go right back to the roots. And then you've got to think about how you engage local people. How do you get them involved once they understand better that it's this little mosquito that is the issue. And of course, largely we've been in the distribution of nets, because that is one of the prime ways we can reduce incidence in that part of the world. But then you have to oversee it. You have to have people who are not just given a net and said, here, hang that out. You've got to follow through. So that's a little piece of the puzzle of this end-to-end process. And then as I look at the overall efforts, and there's some wonderful efforts going on globally on this, I also see too many silos, that we have different organizations who are not liaising with each other in the right way, not combining in the right way, and not working closely enough with the people on the ground or with the health authorities. There's only going to be a very effective solution. Number one, when we work on an end-to-end process. And number two, when we actually join all of the dots of the different initiatives that are going on country by country, because it has to be a country specific answer in terms of solving things, working with the Ministry of Health, and bringing those together into a cohesive whole. It's part of my experience in business that when things aren't working, it's because they've got into silos and people are, in a way, protecting their own interests. That's a rather harsh way of describing it, because they do it with the best intentions. And therefore, I say to everyone today that to the degree that we can think about a holistic approach, bringing everyone together to fight malaria, we'll be more successful. So that's my message today, and that's from my learnings over the last 10 plus years. May we all be successful in eliminating malaria. Thank you.
Thank you, everyone. I'd like to ask Mira and Amu and Brian and Monica to turn your videos back on. We've seen some great examples of leadership over the past few minutes. We've heard of international leadership, national leadership, faith leaders, youth, community leaders. But yet we have a question. Malaria numbers are not going down dramatically. What's missing? If we have all of this key leadership, what else needs to happen?
Thank you, Rebecca. Just to answer that, what needs to happen is everyone needs to get involved, and the training of community, hence malaria elimination. And because health facility might not be enough, but the community health workers will reach a number of people, given enough commodities that they need to cover in terms of testing and treating, which will also reveal real-time numbers. And these will also kind of help reduce the numbers, provided these malaria commodities are available. This is the reason faith leaders are engaging with government to have these in different regions, both at national and sub-national level.
Building up on that, I definitely agree. I don't think there is a one-fit-all solution to help us eliminate malaria. We need to look at this at an ecosystematic level and say that probably we have to bring all people on the table and see what do they have to do towards the fight, so that we join efforts and have ideas cutting across this multidisciplinary kind of setup and convene regularly and be accountable to what we the changes that we are creating in the community. That way we can move faster, because in that way we are also clearly seeing the pathways of the investments that are being done. We are seeing the impact that is being created from the grassroots, and we are communicating change and not duplicating efforts that have failed in other places in new places. I think that way we can move faster towards elimination and zero malaria. Thank you.
perhaps I'd also note that some folks in the chat have made the important point that we have a lot of leadership, but of course we need the fundamentals in place everywhere, the drugs, the medicines, the test kits, the nets. So it's really the convergence of all of these factors coming together that lead to success against malaria. And so leadership is a critical part of that. And I think it's really exciting to see the advances being made at country level, community level with leaders, but that needs to be coupled, of course, with the resources and the commodities to be able to harness all of that really strong momentum. So I think on that front, you know, we're all working on it, but we still have a way to go.
Excellent, thank you. Another question, a theme that's coming out in the questions is around COVID-19. What have we learned from the fight against COVID-19, or what could we learn to increase and improve the work against malaria?
Looking at the strategies that the learnings from COVID-19, I think, for example, we saw communities and countries come together faster to deploy solutions. So that's a key learning that we can definitely take on. We saw a faster adoption of technological approaches, how the data was coming in and how the public and private sector were partnering to make sure that they all address the same issues. So I think those are the main learnings that we can translate into the fight of malaria. How do we create a strong public-private partnership? How do we use technology as an enabler to get to the communities and get that data in real time to help us make the decisions on our efforts to support the programs at the national level. That way we can see, I think we can see a clear pathway to change using those learnings.
Thank you. Mira, anything to add?
I think maybe just to say that it's incredible to see what a sense of urgency can do in terms of having success, and what can we here do to really instill that sense of urgency in the fight against malaria. It's one thing to bring that with something new, but with malaria, I think it's, you know, we've lived with it for generations, but that doesn't mean we should be living with it anymore. And how can we really bring that to the politicians, to the decision makers, to those controlling the resources, I think.
Great. And a comment in the chat that there was rapid sharing of data to help evidence-based decision making. Thank you, panel. We'll move on to our next session. Leslie Ann, over to you.
Thank you so much, Rebecca. Our last panel discussion for today is centered around learning. Indeed, hinging on what we've just been discussing. Confronting malaria requires constant learning and innovation, including through the responsive use of real-time data. We will hear from a variety of panelists who are facilitating the use of real-time data in order to advance malaria elimination. And our panelists include Dr. Busiko Haimanza, the Acting Director for the Zambian National Malaria Elimination Center, also Dr. Elizabeth Chizema from the African Leaders Malaria Alliance and Malaria Council Secretariat Officer, who will be stepping in for Joy Pumafi, Executive Director of ALMA. Alexandra Gordon and Elise Maglior from the JC Flowers Foundation are also on the panel, as well as Dr. Diane Worth. She is a Richard Pearson Strong Professor of Infectious Diseases in the Department of Immunology and Infectious Diseases at the Harvard T.H. Chan School of Public Health. Dr. Busiko, you are very welcome. Please do kick off the final session of this webinar for us.
Thank you very much, Leslie. Good morning, good afternoon, and good evening to everybody who is on this webinar. Thank you for giving us this opportunity to share a few thoughts around our experiences as a country on the use of the malaria scorecard. Next slide, please. So in Zambia, we have integrated the National Malaria Elimination Center and all partner work plans into the web-based scorecard. So we use this particular platform to review the progress that we are making in terms of program implementation on a monthly basis. and we ensure that all key partners participate in these reviews. Prior to the use of this tool, we had an implementation rate of about 36% for the strategic plan that ran from 2011 to 2016. When we introduced this tool and started using it, our implementation rate at a national level increased to 81%. This platform has allowed us to be able to harmonize the various work plans from the National Malaria Elimination Center and the partners. This particular tool has also been rolled out to the provincial and district level. The tool is also used by our End Malaria Council and the various partners to also track activities. The End Malaria Council Secretariat Work Plan is also integrated into this work plan tool, and it allows us to be able to ensure accountability and compare commitments made by the End Malaria Council members. Next slide, please. So the NMEC includes, the National Malaria Scorecard in its updates to the End Malaria Council. And using this scorecard, we have been able to, enable the council members to quickly, identify operational bottlenecks and prioritize areas of support. And this is an example of what happened when we had a stock out of sulfadoxine pyrethamine, which is the drug that we use for intermittent presumptive therapy in pregnancy. When this was presented to the End Malaria Council, it triggered quite a number of responses. As you are aware, our End Malaria Council is chaired by the Minister of Health, and when this situation was detected from the scorecard, the Minister triggered a release of funds to procure additional sulfadoxine pyrethamine from the National Treasury. We had some partners that were not previously supporting the procurement of the drug, and however, from that particular interaction, they were able to procure some additional SP and also include the procurement of SP in the subsequent annual work plans. And at district level as well, the districts also were able to access locally available financing to also add to additional procurement of SP. Next slide, please. So we also have provincial End Malaria councils, and these are also multi-sectoral with political, civic, and traditional leadership as members, including the private sector, other line ministries, and various stakeholders. So even at a provincial level, the malaria scorecard is presented when these provincial End Malaria councils meet on a quarterly basis. And similarly, to the national level, the council members at that level can quickly identify operational bottlenecks and areas to prioritize for support. We have another example here where when the scorecard was presented during these provincial meetings, that there was a need identified for storage of bulky malaria commodities, such as the insecticide-treated bed nets, as well as insecticides for our indoor residual spray campaigns. The members of the council, essentially the private sector, came to the fold and were able to say that they would be able to provide storage facilities for these particular commodities. Additionally, they were able to also foster or support transportation of these commodities to where they were needed the most in the rural areas where the recipients were to receive these services. Additionally, from this particular scorecard, it also triggered advocacy at a local level by traditional leadership to ensure that there was an increase in terms of acceptance and use of these malaria interventions. So these two quick examples just show or highlight how data visualized and communicated can actually trigger very powerful reactions or interventions or responses that then guide into trying to mitigate the burden of malaria across the country. This is my last slide, and I just want to thank you for your attention and wish to thank all the partners that keep supporting malaria. Thank you so much. Over to you, Leslie.
Thank you so much, Dr. Haimanza. We will now hand over to you, Dr. Elizabeth Chizema, for your brief presentation. Thank you.
Thank you very much. Hello, everyone. Excellencies, ladies and gentlemen, I just want to send warmest greetings and wishes from Joy Pumapi, the AUMA Executive Secretary, who was unable to join us today. She does send her deepest regret, and she wishes us successful deliberations. I take this opportunity to also thank the J.C. Flowers Foundation for organizing this webinar in collaboration with Harvard to share on how we can harness our knowledge, constant learning, and innovation, including responsive use of data and real-time data. AUMA takes this opportunity to highlight the importance of keeping malaria high on the global health and development agenda. We recognize the importance of high-level political advocacy and leadership in the fight against malaria. Today, the malaria fight is at the center of attention, with global malaria deaths much higher than previously estimated, and half of the world's population still at risk of the disease. Unfortunately, the countries with the highest burden of malaria have the least ability to fund health services and have suffered the greatest economic impact from COVID-19. Countries in Africa did not achieve the goal of reducing malaria incidence and mortality by 40% by 2020, a key milestone to eliminating malaria in Africa by 2030. This therefore calls for more concerted efforts to stem the tide against malaria in the context of COVID-19 and emerging epidemics. African leaders need to accelerate action in order to push for continental goals of eliminating malaria by 2030. We need to advocate and mobilize new coalitions of malaria champions at home and abroad, and engage the youth in this fight as the future generation. And you did hear from the youth themselves as Brian spoke. We also need to innovatively mobilize additional resources, invest in market shaping initiatives, and undertake food procurement to help address the higher costs of next generation commodities and new interventions, while addressing barriers in local manufacturing through the African Continental Free Trade Area, as well as to mobilize regional economic communities and support national regulators. Increasing coverage of essential life-saving interventions and reaching those hard-to-reach communities is as crucial as ever and remains one of our biggest challenges. As in order to make real programming decisions to drive impact, it requires the availability of real-time data. As of today, and as you have heard from Zambia, HAUMA has supported 40 countries in the development of malaria scorecard management tools. These are country-owned tools that use real-time data to identify bottlenecks and actions in response to these bottlenecks, thus driving action to improve performance. These scorecards are used at various levels, at political level, including by the parliamentarians, and has resulted, for example, in enhanced resource commitments. Scorecards are also used by ministries of health, their partners at national, subnational, and community levels, where now we have communities have their voice. Scorecards have helped to address stockouts, upsurges of malaria, and have helped also to fill resource gaps and keep malaria high on the development agenda. Improving access to malaria data through a digital platform and by using country malaria scorecards allows citizens to be aware and empowered to act in the context of Zero Malaria Starts With Me. AUMA has worked with countries to develop and decentralize the use of scorecards, and including building capacity of subnational and community stakeholders to use digital data, and in linking scorecards to the national health information systems to ease the use of digital data for decision-making. The country scorecards are published at the Continental AUMA Scorecard Hub. which was launched by the chair of AUMA, His Excellency, President Kenyatta, last year. This is a learning platform which promotes transparent sharing of country scorecards and country best practices. AUMA is also working with the regional economic communities to promote malaria cross-border collaboration, strengthening data use, and cross-border evidence-informed interventions. The African Union Constitutive Act, the African Youth Chapter, and the African Union Roadmap on harnessing the demographic dividend through investments in youth provide a solid policy and strategy foundation for youth development and empowerment, underscoring the importance of youth participation and involvement in the development of a continent. Addressing malaria is a key lever in achieving the vision. AUMA recognizes the importance of actively involving youth in order to eliminate malaria by 2030 and strengthen the health sector. We cannot achieve the Africa we want without youth leadership and contribution. AUMA, in collaboration with the African Union Commission, trained 100 youth innovators on youth leadership and development, and trained more than 1,000 malaria youth champions on malaria scorecard use, on advocacy and communication, on resource mobilization and leadership, to build youth capacity in malaria and leadership, and to allow the youth to advocate for malaria elimination and the expansion of universal health coverage, while mobilizing collective youth-driven solutions towards ending malaria. In conclusion, I would like to invite all of us to keep the momentum in aiding youth and enabling their contributions in the fight against malaria. The growth of the innovation sector shall be enhanced and significant opportunities created for transforming youthful energy into new ideas. Zero malaria starts with me, zero malaria starts with you, with all of us. I thank you.
Thank you so much, Dr. Chizema, and sorry to cut you short. We have a few precious minutes left, and we would also like to give the opportunity to hear from Elise Maglior and Alexandra Gordon.
Thanks, Leslie Ann. We are going to briefly share with you how Isdal Flowers uses locally collected household survey data to facilitate community action for malaria elimination. Isdal Flowers Cross-Border Malaria Initiative works through networks of local faith organizations, community health workers, traditional leaders, and local volunteers using community-based strategies in Angola, Namibia, Zambia, and Zimbabwe. We also care that these strategies are informed by high-quality data that is locally and recently collected, and that communities are centered in every part of the process. So to do this, we facilitate an annual cross-sectional household survey that assesses malaria-related knowledge, attitudes, and practices, we call it CAP, within Isdal Flowers program areas. It's important to note that community leadership and community volunteers are involved in the planning phase, the data collection phase, and as we will learn more about later in the presentation, the results interpretation and action planning phase of the CAP survey. The survey questionnaire measures key indicators on insecticide-treated nets, indoor residual spraying, intermittent preventive treatment of malaria in pregnancy, care-seeking behavior for children under age 5 with fever, and malaria-related knowledge and attitudes towards these things. We don't have time now to go through each of the specific indicators, but if anyone wants more information on what we measure or to learn more about the results, please do get in contact with us after the webinar. We'll be happy to have a discussion. So there are several levels at which CAP survey results are put to use. Full results reports are shared with government partners at the national, subnational, and health facility level. Advocacy briefs are developed to highlight issues beyond community control, to contribute to ongoing advocacy efforts led by faith leaders at the national and subnational levels. At the program level, results guide ISDEL Flowers program activity prioritization. And finally, and perhaps most importantly, communities receive results reports that are relevant to their local area and gather to develop community action plans. We call this process community CAP action planning. And I'll now hand it over to my colleague, Alex, to tell you a little bit more about it.
Great, thank you, Allie. So we know that this type of data is most valuable when it's put in the hands of those who are most affected by malaria, so that they are the ones who can take informed action and have ownership over malaria elimination. And so this CAP action planning process enables this. In late 2021 and early 2022, ISDEL Flowers program staff facilitated more than 40 meetings across the 4 countries with local committees that were made up of community leaders, health workers, and other key community figures. These committees were able to view summarized CAP data, which highlighted gaps in desired behavior. So for example, lower than average net use might have been an issue highlighted. And then these committees came together to discuss barriers to the desired behavior and work together to make action plans in order to address those barriers. And so a lot of great ideas came out of those action plans, but I'm just going to highlight a couple examples. So next slide. So one example here from Hurungwe, Zimbabwe, it was noted that caretakers were not taking their febrile children to seek care promptly or sometimes not at all. And this was highlighted as an issue. When this was discussed among the committee, they noted that village health workers in that area did not always have a consistent supply of test kits when they were at the village level. And this was because they only had those test kits during outbreaks. And so as part of this conversation, the district nursing officer was engaged, and they enabled the village health workers to have these test kits at all times so that local testing and treatment would be available, and those caretakers would not have to travel long distances and spend lots of money seeking care. So we expect that care-seeking behavior will improve when we see our CAP data next year. The next example here from Livingston, Zambia, we saw that about 10% or some pregnant women were not taking the full recommended dose of preventive treatment when they are pregnant. That's IPTP. The community health workers in this committee really came together to discuss why this would be, and they felt that there wasn't enough knowledge getting out to all of the pregnant women about the importance of taking IPTP. The community health workers were also able to bring up this fact that there are other community groups that exist, such as the Safe Motherhood Action Group, or the SMAG, who are working directly with pregnant women. So it was their idea to really join forces with these SMAG groups, and that enabled them to reach even more pregnant women more often and more regularly. So this has been really successful and a great collaboration between these two community groups for the benefit of pregnant women and their health. And so this is a model that's going to be expanded in Zambia in 2022 with our program officers and field officers there. And so we're looking forward to the 2022 CAP survey results, again, to measure the effectiveness of some of these ideas. Thank you.
Thank you very much to you both, Elise and Alexandra. Next and last up, we will hear from Dr. Diane Worth.
Great, thank you very much. And it is indeed a pleasure to be here and to hear many of the ongoing activities, particularly those sponsored by the Flowers and ISDEL foundations. I'm going to step back and talk about a global consultation on rethinking malaria in the era of COVID-19 that was chaired by Professor Rose Leakey and really followed and consulted a wide range of stakeholders with a focus on working with those on the front line and those affected most by the disease to consider the global malaria challenges and the opportunities in the context of COVID-19. I think we all know on this call, and we've heard, malaria elimination is possible. Just take the example of China going from 30 million cases to 0. However, Africa's progress has stalled. I think Rebecca pointed this out a number of times. In fact, today, one might argue that the burden of malaria is similar to that in the year 2000, or certainly in the year 2015. But COVID-19 has also kind of changed our thinking. It brought the fastest vaccine and diagnostic developments in history. And it is possible to bring this kind of intense innovation to a problem. And we hope that some of these lessons can be applied. As we've heard today, many are already being applied. COVID-19 also laid bare the limitations and inequities in our global health system, in particular challenges related to governance, service delivery integration, and workforce. And these also apply to malaria. And so what did we conclude after all these consultations? What needs to change? We've already heard this, but I think it's worth emphasizing. Malaria needs to be viewed as a societal problem of development, not a medical problem. It is not a medical problem alone. Leadership. We've heard a lot about leadership. It's critical that the leadership be in endemic countries and at all levels. But we also need to invest. We need to invest in the workforce. We have to empower them with readiness, training, and education. And we've heard this from many of the speakers, including appropriate compensation for community health workers, whether that's monetary or other types of compensation. But also critical, and we've just heard this in the last couple of talks, the visibility and use of reliable real-time data, knowledge, and information. Every country in the world had a COVID dashboard within days of the pandemic starting, yet few countries actually have malaria dashboards. I think the End Malaria Council is doing a great job of beginning to think about this. But again, these need to be real time and they need to be used for decision making. And we've heard some great examples of that. But in addition, we have to think about accelerating innovation. In general, we need to give greater attention to innovation, including local innovation and problem solving for malaria elimination. And we need to support endemic country entrepreneurs in R&D and in manufacturing. And finally, I think, importantly, we need to strengthen the health system. Health for all means solving malaria as a pillar of universal health coverage. But malaria cannot stand alone. I think Mr. Isdell talked about silos. It is important that there be integration. So what I would say is, in many ways, this is an exciting time, but also one with great challenges. But I would say to this group, now is the time to imagine and to keep working toward a malaria-free world. I think we all know it can be achieved. Thank you.
Thank you to all. I'd like to invite this last panel to turn your videos back on. A very simple question for all of you, and I'd love to hear answers in just a couple of words. What are the elements that enable data to transform itself into action? The data abounds. There are databases and databases. What is necessary in order for that to actually serve for the goal of malaria elimination? Dr. Busiku, could you start?
Thank you very much, Rebecca, for that question. I think that it's about how that data is translated for those that make decisions to be able to interpret and be able to understand. It's essentially using data as part of our intervention process. What does it mean when we are seeing, an increase in incidence of malaria? malaria? What does it mean when we're seeing an increase in mortality? So how do we interpret that information to actually drive an action? So it is how we package the data for what you could call a non-expert community, in a few words. Thank you.
Excellent. Dr. Shizema, Ali, Alex?
I would agree.
Go ahead, Dr. Shizema.
Thank you very much. Just to add on what Dr. Busiku has said, it's really near real-time data that is simple and easy to use. It should be country-owned. When you look at community use, the communities themselves must own it. And yeah, basically, I think those are the key elements for data, which can be used for decision-making.
Alex?
Yeah, and I think in our examples, we've packaged that data in a variety of different ways to be used by different audience. So for example, this CAP data has been used to create advocacy briefs for faith leaders. It's been used at the community level by making a different type of report. It's been given to national malaria elimination programs for different use. So I think, as colleagues said here, it's about translating and packaging that data in a way that's going to be useful to different audiences.
Yeah, I would also just add that I think in terms of sharing with communities, it's not only important to share, but to involve them from every step of the way from the very beginning. And I think that increases community action, community ownership of the data.
Thank you.
Yeah, what I would say, and I attribute this to Evelyn Ansah, who led the integration working group. I think, you know, she has this wonderful cartoon of people holding helium balloons with data written across the balloon. And what happens in many cases is data is just released and goes into the atmosphere. So having data used locally, I mean, you know, just look at the example of COVID. Understanding how much transmission there was affected closing of businesses, masking mandates, and many other actions. Whereas for malaria, we don't have that kind of data generally available at and in a form that decision makers can say, you know, we need to increase bed nets or spraying in this area because we have an immediate problem. And I think that's where we want to be. And then in the longer term, sort of on the year-over-year basis, this data needs to be used to stratify countries in their approaches and their use of interventions. So I think many places, and it's a key element.
Excellent. Well, thank you very much. Dr. Worth, do you have any final comments? We are closing our sessions here now.
I understand, and I just want to thank all the speakers. I found this incredibly interesting, and I think also, I must say, this is kind of rethinking malaria implemented, and I'm very pleased to see this level of interest in just re-examining what we do with an old disease and both an old set of tools and the new and emerging tools. I am quite optimistic with the recommendation of the first vaccine for malaria. It's not perfect, but there'll be more, and this will increase innovation. I also feel this is the time to really encourage and support innovation in the African region. There are many talented people with great ideas. We just need to give them a chance to act. And so I'm a strong supporter of that and very optimistic about the future.
Thank you very much. And thank you, Dr. Worth, for the co-sponsorship with Harvard University work on this webinar.
Great.
The J.C. Flowers Foundation has been honored to hear from and learn from all of you. And I see a lot of people nodding their heads in the chat and in other ways, WhatsApp, things are going crazy. But what matters is what we do from here on out. And at the core of this work are the people, those families, 627,000 families who lost children last year, children who probably a week before had been playing vibrantly and then were buried. And the many millions, hundreds of millions of people with malaria who have to spend money on transport, who miss school, who can't work properly on their farms, That's why we're doing this. This is not purely an academic or technical exercise. So I encourage each of you as we go out to think about how are we going to break down these silos? How are we going to show leadership? And how together will we indeed eliminate malaria? Thank you very much to all. Goodbye.